So we very well appreciate that the B-cell receptor in response to antigen is an important signaling mechanism in CLL cells. But I want to point out this, it doesn't only regulate proliferation and survival, it's also directly regulating migration and to some degree localization of cells, and of course also drives the maturation in normal B cells. And ibrutinib, as we know, hits one of the essential kinases, meaning a kinase that if you knock it out in mice, there's a severe B-cell defect. I would like to discuss data from our investigator-initiated trial at the NIH, where we have two patient cohorts, one cohort patients with 17p deletion, and one cohort elderly patients older than 65. And we enrolled both treatment-naive and relapse refractory patients into these cohorts. Treatment is standard, 420 milligrams daily, continuously. We restage at 6 months, and the data I present to you today will be these first 6 months mostly. But patients continue on treatment for as long as they benefit. So here is our take on the lymphocytosis. This shows the mean ALC count, and you see that there is an immediate upswing in the ALC, and it's actually the day 2 is the first data point there. So 50% increase with 1 dose of drug. This shows you the time to peak. So at what point within the trial do patients reach the peak of their ALC? And 40% of our patients have their peak on day 2. And virtually everybody has peaked by 2 months. But there's considerable heterogeneity. And to dissect this heterogeneity, we actually just tallied up the lymphocyte counts and submitted it to a hierarchical clustering analysis that lets you discover patterns you may not have known about before. And we actually found 3 patterns of how this lymphocytosis comes about. On the left, you see the absolute ALC count. On the right, the percent change in ALC. And so we have 3 different groups that we identified. One group that has an almost immediate dramatic rise and then also a rapid fall in the lymphocyte count. So that's the cluster 1 in red. We have patients who gradually increase their lymphocyte counts over the first 2 months and then are slow to resolve it. And then there's an intermediate group. So does that have any correlation with clinical parameters? Shown here is first observation was these patients who have this immediate rise and then rapid drop are patients who start actually with a higher lymphocyte count. So the ALC, the pretreatment ALC is significantly different between the 3 groups. But importantly also there is some differential expression of clinical markers. So cluster 1 has more often IG unmutated CLL, which is consistent with the data also from the New England Journal paper that the mutated patients are slower to resolve their lymphocytosis. The group that has this protracted rise and slower resolution of the lymphocytosis is enriched for patients with bulky lymphadenopathy. And again, patients who have this quick rise and quick resolution are patients in more advanced rise stage, so actually patients who have cytopenias. So where do these cells come from? We talked already a little bit about this interchange between blood and tissue. So if the cells come out of the tissue, well, let me introduce that. So what we know in CLL is that in the tissue, CLL cells are proliferating. So they have higher expression of Ki67. They also have higher expression of CD38. Whereas in the blood, cells are quiescent and have lower expression of Ki67, lower expression of CD38. So we can use these markers to address the question whether the cells that form this lymphocytosis are stuck in the blood or are released from the lymph nodes. What we see on day 2, again, that's with 1 dose of drug, is that in the peripheral blood, the percent of CLL cells with higher CD38 expression increases. Equally, the Ki67 expression increases. This is counterintuitive, as we know that ibrutinib turns off B-cell receptor signaling. And by day 14, we actually see that both CD38 and Ki67 are significantly reduced. So it's just a transient blip of cells that have higher Ki67 and CD38. And the way we think, what that tells us is really these are cells coming out of the tissue. Is that the whole story? So what we try to model here is to understand to what degree is this lymphocytosis due to release of cells out of the lymph node. And the way we did it is we measured the ALC pretreatment and on day 2. In this patient, it went from 90,000 to 128,000. We measured in cells from the lymph node Ki67 expression pretreatment, and we also measured that in the peripheral blood. And you see here in the lymph node, Ki67 is expressed in 12.8% of cells, in the peripheral blood in 6.4%. If the whole increase, if this whole addition of 38,000 cells is due to cells coming out of the lymph node, our predicted Ki67 expression rate in the blood would be 8.3%. And what we measured on day 2 is 8.2%. And we could do this in 8 patients, and we had a perfect alignment. This, to me, suggests that really on day 2, all the cells that are in the blood, newly in the blood, have been coming out of the tissue. We then wanted to understand a little better the overall distribution of the tumor burden in the patients. And in addition to having the absolute lymphocyte count and the spleen volume from CT scanning, we also have bone marrow biopsies, and we, in a subset of patients, did lymph node volumetry. So we basically, on a CT scan, measured the volume of all the lymph nodes in the body. And that's shown in this lower panel here that shows you a graphic representation of the lymph node volume. We then, from all this, calculated out what is the number of cells in all these compartments. So what's the number of cells in blood, in bone marrow, in lymph node, and in spleen? And here I show you 2 patterns of what the distribution of disease burden looks like at the time that we start ibrutinib. So we have here on the top a patient who has primarily disease in the peripheral blood and bone marrow, and spleen and lymph node are only a minor reservoir of the overall tumor burden. In the lower part, we have a patient who has more a SLL-type pattern, so bulky lymph nodes. The majority of the disease is in the lymph nodes. So what happens now on treatment? So here you see 2 patients on treatment, so we have reduction of disease in the bone marrow. This patient had a very good response in the bone marrow by 6 months, and you see this reduction in lymphadenopathy. So again, for all these 3 time points now, we calculated the total tumor burden and its distribution. So in this patient, we see a very rapid decrease in total tumor burden, and a lot of it is actually the blood and marrow burden that decreases. Lymph node was not a significant reservoir of disease in this patient, but it's resolved by 2 months. Another pattern is shown by this patient with the bulky lymphadenopathy. Very rapid decrease in the disease in the lymph node, so that's the green curve, with not much change in the bone marrow and actually this lymphocytosis here, so there's a relative increase in the amount of disease in the blood. So we have a shift from lymph node to blood. And this is a patient where, if we just look at it at face value, this is actually somebody who had an increase in tumor burden by 2 months. And this increase in tumor burden is totally driven by this huge amount of tumor in the blood, whereas spleen, lymph node, and actually to some degree also bone marrow decreased. So here, I think this patient did not progress. This patient did well and reached the same response by 6 months as other people. I think it shows a little bit the limitation of our modeling because we are not assessing one compartment that is very important, and that's the gastrointestinal tract. We know from literature, from the immunology papers out of the 80s, that actually in normal B cells, a big reservoir of normal B cells is in the mucosa of the gut. And there are a couple papers that looked at this in CLL, and they also found significant involvement in the gut. So I think here we have mobilization out of tissues we are not able to assess. So are these cells actually all equally targeted by ibrutinib? So we already talked about in the blood, we see this downregulation of Ki67 expression, and that's sustained throughout the first 2 months. What we see in tissues is a reduction in Ki67 expression in the lymph node. Now this is on day 2. So this is very early, 1 dose of drug, and Ki67 is not immediately lost from cells that have proliferated. So there's a little bit of lag time till they become Ki67 negative. In the bone marrow by day 56, we have a similar strong downregulation in Ki67 expression. So even though these are not all the same time points, in all 3 tissues we can assess, we see that proliferation is inhibited. Is the signaling pathway inhibited? This is after 1 cycle of, so 4 weeks of ibrutinib. BCR signaling strength measured as target gene expression is decreased by a mean of about 80%, and NF-kappa B is also greatly decreased. This was the blood, and we see similar effects in the tissues. Again, in the lymph node, this is after only 1 dose of drug, whereas here in the bone marrow, after 2 cycles, 2 months on drug, we have this 70 to 80% reduction in signaling strength. To summarize, treatment-induced lymphocytosis develops really rapidly. We actually also did 4 hours in a subset of patients. We see the upswing of the lymphocyte count already at 4 hours. And in our patients at least, often peaks by 24 hours. This increase, at least early increase on day 2, appears to be due to an efflux of cells from the tissue sites. We cannot do the same analysis at later time points because the markers we rely on now are turned off by ibrutinib. So Ki67 is low, CD38 is low. I skipped that part, but what we saw that the adhesion capability of the CLL cells is greatly reduced by ibrutinib. I think that's one of the contributors for actually getting the cells out of the tissues. The distinct patterns of lymphocytosis correlate with pretreatment characteristics, as I've shown you, but actually did not correlate with the degree of nodal response by 6 months, going with data that Jennifer presented us, that this lymphocytosis does so far not appear to have any predictive value for overall response and PFS. The disease reduction in the lymph node overall was more rapid in general than in the bone marrow, but by 6 months we have many patients who have virtually completely cleared the marrow. And BCR and NF-kappa B signaling and tumor proliferation are reduced in all sites we can assess: blood, bone marrow, and lymph node. I would like to acknowledge our patients for volunteering and contributing all these samples to the study. Mohammed Farouki is leading the clinical trial, Sarah Herman the translational analysis in the lab, and the agent was provided by Pharmacyclics. Thank you.